So yeah, like Peter said, I'm from the US, just here for the summer from July to September as a visiting scholar, but typically I'm doing my PhD in Israel. So I'm kind of everywhere, but for the next 2 years after this, I'll return to Israel and finish my PhD there in September, well, for 2 more years. Today I thought we could talk about, I would talk some about my background, just so you kind of know where I'm coming from, and study the background of the study, which was done in the Netherlands, and then go through the study elements itself, so the research questions, my data, and the method, and then I would like to get your feedback because I'm very close to finishing the analysis, but I would like some feedback from you as well on that in a discussion. So first, I'm from Kentucky. Kentucky is here, in case you aren't familiar with the map of the US. And I did my bachelor's in healthcare administration at Western Kentucky University. So healthcare administration, kind of the equivalent term here is management, I think, and long-term care certified. And my bachelor thesis was on intergenerational living between college students and senior housing residents. And this is how I originally got interested in care in the Netherlands, because they have a model there that's pretty well known. And then shortly after that, I received a Fulbright grant where I collected the data for this study that I'm going to talk about today in the Netherlands. And I was there for the academic school year and collected data that I will talk about. Oh, and this is Kentucky. We're known for our horses and also green hills. So. No, this is just an image from the internet, yeah. So, like I said, currently I'm an early stage researcher with the Ageism Network, which is a multidisciplinary, intersectorial, international network of 15 early stage researchers who are from all over the world, but we're researching ageism and different aspects of ageism in 8 universities across Europe, plus Israel. And so the focus is like to bridge science and policy. So 2 of the ESRs are here, Abu Jurin and Nasir, they're here today as well. And then 4 of us are in Israel, that's where I am full-time. And so with the network we have also 6 partner organizations like the World Health Organization and Age Platform Europe. So it's a very extensive network. And as part of the program, we complete 2 secondments while we're here. So that this is the first secondment that I'm doing here at Robert Gordon University. And that was from our training event a couple weeks ago where we had all of the Ageism researchers here at Robert Gordon. So I wanted to start with some just general background on long-term care that many of you are probably very familiar with. And then move into more specifically to the Netherlands. In the last 30 years, there's been a shift in the culture of long-term care away from the medical model, more towards person-centered care. And so this is really focusing on a person's preferences for their routines and for their own care. But the adoption of person-centered care has been arguably slow since its inception, especially in long-term care, due to several factors. And so 2 of the main parts of person-centered care are consumer-directed care and autonomy. And so this presentation is not really on person-centered care, but it's just to place autonomy in its context of why it's important, why we're talking about it in long-term care right now. And so there are several definitions of autonomy. Bart Colopy described it as a loose system of interorbiting concepts that trace out the varied paths of self-determination. So there's many definitions, but the approach that I take in this study, in this presentation, is it's really about self-direction and the freedom to make your own decisions and self-determination. So the Netherlands globally is known for a lot of their innovative care models. And so like this photo is from Humanitas, which is, like I said, how I was first interested in the Netherlands, where college students live in a nursing home for free in exchange for spending so much time being good neighbors to the older adult residents. So I was able to visit there, and that's what first got me interested, but they also have other innovative models like the Dementia Care Village, which is like in a secure environment, but it's like made to look very realistically like a typical village. They also have like green care farming, things like that. So the health ministry there is very encouraging of innovative care models. And the age demographics, just a little bit about that. Currently, the age 65 and up is almost 20% of the population and is expected to increase like everywhere. And those age 80 and up, who are like those people who are most likely to receive long-term care services, is going to increase to over 7% expected by 2030, which is more than the EU average, what's expected. So just a few years ago, then, in the long-term care system in the Netherlands went through a reform, and so they're still working through it now, but they really shifted their focus to keeping people at home as long as possible, and there are fewer people who are moving into care homes. And so they wanted to make financial changes as well, because although they're quite focused on their quality of long-term care, it comes at a price, and the Netherlands pays more for their long-term care than any other country in the OECD. So that was part of the motivation for the reform, and also to focus more on quality of care and to improve their quality of care. And so this change to staying at home also came with like a societal change as well, where it's a shift towards a more participatory society, or like where it's more individualized, and they're encouraging people to be less reliant on the welfare state and more individualized, or you could say autonomous in a way. And so as part of the reform, one of their top 4 priorities was on quality of life. They said that they wanted quality of life of people receiving long-term care services to be improved, and this is something that they really want to focus on. So with the reform came then the 2017 quality framework for nursing home care specifically. And this was a big reform, and it changed the way that care inspection happens within the care homes. And so something that I found particularly interesting is that they really wanted to build confidence in nursing homes and with the staff and the managers, and also to instill trust between the care inspectorate and the nursing home staff. They want there to be like a very, they want the relationship to be more trusting and less like skeptical of each other, or like less distant in a way. And then also they have a big focus on improving care. Like the inspection wants to see that that the focus is always on improving, and there's always like a learning process that's taking place, as well as like preventive strategies. And so then this also changed the way that the inspection visit takes place when an inspection comes into the facility. They used to be very like regulated with a checklist, and now it's more they come in, they sit, they observe, they want to take in like the general atmosphere, and they really want to focus on the residents' experience, and they're less reliance on the checklist, I guess. And this really, you can see that the relationship between the care inspector and the nursing homes is changing. So this is a Dutch saying. I'm going to attempt to say it. Ja, eigen boontjes dopen, which is snapping your own green beans. This is a kind of a typical Dutch saying, which sort of means like do what you can, or take care of your own stuff, organize your own things. And I thought that was kind of appropriate because this is reflective in a bit of the Dutch culture in a way. So I was really curious to know what the manager's role in this reform looks like. because I think the managers play an important mediation role between the care inspectorate and the care that's delivered within the nursing home. And they play a major role in like setting the tone of the care home, I think. And so in order to understand more about resident autonomy and what that looks like in a home, we need to understand the manager's decision-making process and all of the factors that they have to take into account. So my research questions were, how do managers perceive resident autonomy, just in general? And then how do those perceptions of resident autonomy interact with other factors of their decision-making process, because there are many things that they have to take into account. And these research questions are done as part of a secondary analysis, which I will explain a little bit further. So this data was originally collected to understand how managers weigh between quality of life and safety. And so after the initial analysis, we saw that the concept of resident autonomy could be further explored, and I found it particularly interesting. And so the sampling procedure was proposive, which really to have a range of leadership positions within the organization. So we have some who were like a single location manager, some who were a manager of more than one location, and then some who were the director of like organization-wide. And then also we wanted to have a range of locations within the country. So it wasn't just in the urban centers, but it was throughout the country. And most of the care homes offered both somatic care for like physical impairments and dementia care as well. So only, I think, 2 of them were just solely for memory care purposes. And so I conducted 15 interviews, or semi-structured interviews with 15 managers of these care homes. All of the interviews were done in English throughout the school year. And after the interview, all of the participants were sent an interview summary and a narrative report as a member check. So like I said, this is a secondary analysis, and I used the QAGL framework, the Qualitative Analysis Guide of Leuven. And with this method, it's a step-by-step process that's done in a team of researchers, and it's a forward and backwards approach to the data. And so it helps the researcher establish a familiarity with the data after thorough preparation for the process before coding. So there's a lot that goes on the back end before coding, and then we finally get into the coding process, but by that point you're very familiar with the data. And so in order to do the secondary analysis, we adapted each of the conceptual schemes and the list of codes, and then I did line-by-line coding of all of the interviews, and then with 2 other researchers, we had 5 shared interviews among us to compare our coding process. So again, we were looking at how do their perceptions of resident autonomy interact with other factors of their decision-making process. So I'm nearing the end of my analysis, and I'm narrowing my results, but the nature of qualitative data can be difficult to narrow your storyline and figure out what you want to write up after you've gone through the coding process. So I'm still in the process of killing some of my darlings. Like there are some things that you really think, oh, this is so important, but also this is really important. And so that's what I want to talk about today. And like I said, I'm still narrowing it, and I would be glad to have your feedback on what you think is also really important. So far, the results that I have are sort of broken into 3 themes. The first is resident autonomy, the route to achieving the vision, which I'll explain further. The second is the discussion that takes place, and this is the tool for the decision-making process, is discussion. And then the third are the factors that interfere with the vision, so the factors that might interfere with resident autonomy being preeminent, let's say. The first theme, resident autonomy, the route to achieving the vision. So first, overall, what came out of the data is that the manager's vision is really focused on quality of life and well-being of the residents. Like, this is what they say is number one priority for them, and this is what they want to fully support. And so with this comes like a focus on the individuality of the resident and keeping their authenticity as much as possible. So they describe like they want to preserve their old lifestyle as much as possible before they came into the care home and now that they are in the care home. And so this really means that they are supporting resident preferences for their care and daily decisions and their routines. This is like following a lot of the person-centered care approach, we could say. And so in order to like achieve quality of life and well-being, they talk about autonomy as a way to achieving that, like supporting resident autonomy, encouraging that their choices be supported, and that this is a way for a person to have improved quality of life if they have control over their own decisions. And they also express that they feel that they are very supported by the care inspectorate since the reform, because the care inspector is also wanting quality of life as a priority. So they feel very supported as well, like they're not in so much contrast with them. But I'll discuss that a bit further. So this is one quote. She says, so the movement is from care to well-being, focus on well-being. And I see that here at our organization as well. People are more focusing on well-being. What can we do to improve the well-being of our residents? And as a plus, their care needs are lowered. And then another interviewee said, my passion and vision 20 years in the nursing home with older people with dementia is always be who you are. And this is something that several of the managers said as well, to be who you are. And this is like very important. And this is a way that they sort of define quality of life in a way. So the second theme is on the discussion that takes place. And this really happens especially when the manager and the nursing staff are creating the care plan with the resident and their family members. So they listen to the resident and the family and to understand what their wishes are for their care. And then they discuss their expectations regarding the delivery of care, like what they would like and what they are expecting in terms of like how involved the family is, or what kind of preferences the resident has. And then the managers, some of them talk about informing the family members and the resident about the condition that the person has or the dementia process and what they can expect, because this is a lot of times if someone is moving in, it's sort of in a crisis moment, like an incident has happened maybe, and so the family sometimes expresses fear as well. And so the managers really see part of their role as informing, like, this is what you can expect in the dementia process and when you come to visit, and how it might progress, or whatever disease or condition that the person might have. And they're also informing like what the care home can offer. And then finally, the potential consequences for their decisions. So there's a lot of like weighing that happens between like decisions that are more safe versus those that are supporting more quality of life. And so one example of that, first then I'll talk about this too. The discussion oftentimes turns persuasive in a way, where the manager wants to guide the family and the resident towards their vision of quality of life and well-being. And then through that, also the autonomy of the resident. So this happens when they're evaluating the risk of a decision. So let's say, I'll come to that in a second, sorry. So there's a person who's at a very high fall risk, who's moving into the facility, and they're trying to determine if they should use restraints or maybe if they should use techniques to try to keep the person seated so that they're not up and walking alone or unattended, where if they might fall, then there could be consequences for that. So the manager would then explain, like, this is what could happen if you use the restraints, like you would be very safe. But this is what would happen if you decided not to use restraints and if we encourage the person to be up and walking around the facility. And so this is something that one of the managers, when he was talking about that, he said, so we say, go walk. And we are discussing with family and with all the treaters, like the doctors and the physiotherapists and the disciplines, the care team, the family. We make an appointment that, okay, and we are all accepting the risk of falling because that's more valuable for someone's quality of life than sitting and being tied up in the chair and not falling. And when someone falls and he breaks his hip or dies, well, at least someone could have lived like he wanted to. So this is really like saying something. This is quite a consequence. We know that breaking a hip can lead to then a series of it's the beginning of a chain of events that where someone can decline very quickly. But this is, you really see the weighing that takes place, and then they're choosing quality of life, and they're encouraging, in this discussion, they're encouraging the family and the resident to also choose quality of life. So they're talking about expectations, potential consequences, but then ultimately the decisional authority, like the person who makes the decision, is the resident themselves, or a family member if the person is deemed not able to make decisions because of reasons of cognitive impairment, perhaps. And this is another example, just about the process. She said, and we agreed on that, and that's signed on paper, that the family and the resident agree that well-being is more important than safety. So sometimes they do break things, but that's something they accept as a consequence of that well-being is more important than safety. So you see, this is the weighing that happens, but also then it's signed on paper. So this is like something that everyone agrees on, and then they put it in the care plan and they say, this is what we discussed, this is what the family wants. This example of somebody being up and walking in the facility is something that was brought up a lot. But there are other examples as well, like maybe when they're talking with nursing staff, and they're saying like, okay, how are we managing all of the different duties that nurses have nowadays in a care home? And they're saying, okay, you know, maybe you didn't like check to make sure that the milk wasn't expired today and you didn't sign the paper, and that's okay. That's not something that's very important. Like, we'd rather you be focused on the resident at this point. So there's a lot of like discussion on evaluating like what's most important. It's the quality of life and the well-being of the person. So far I've discussed the first two themes. And from that, I want to kind of take a step back and talk about some of my analysis process as well, which I've also been considering the concept of paternalism. Because paternalism, which is interfering on someone's decision-making process, paternalism is often seen as like kind of the opposite to autonomy, right? Here, Beauchamp and Childress define it as the intentional overriding of one person's preferences or actions by another person, where the person who overrides justifies this action by appeal to the goal of benefiting or preventing or mitigating harm to the person whose preferences or actions are overridden. Now, paternalism is really widely discussed in healthcare ethics. It's also discussed in terms of the decision-making process that happens in long-term care homes. And in the literature, there's this distinction between hard paternalism versus soft paternalism. And so there's a lot of differences in the literature on how these two are like distinct, but from my perspective, the approach that I would take is that it's really based on the approach that you take to interfering on someone's decision-making process. So basically, in hard paternalist view, if we would say that society's goal is to have increased health or better health, then a hard paternalist might say, okay, we should outlaw or totally ban cigarettes and just remove the temptation altogether because we know that it's not good for us, so we should just make them illegal. This is a hard paternalist approach. But a soft paternalist would say, okay, what's the goal? Like, what's the long-term goal? What's the vision? They would work to educate or inform people about the consequences of their decisions. They would try to steer or persuade, and then they would try to persuade the person to make the choice that they think is correct. But then ultimately that person still has the freedom of choice to make, or the decisional authority. So for example, if I was trying to cut out sweets from my diet and I was trying to have a healthier diet, and I'm at a cafe with a friend and I see a big piece of chocolate cake, and in the moment I'm really tempted to eat this chocolate cake, and my friend, if she's a soft paternalist, she would probably remind me of my long-term goal, like, hey, but remember, you want to have a healthier diet. She might tell me the number of calories that are in this piece of cake or whatever. It might try to inform me about it. And she might really try to persuade me to choose something else. But in the end, I would have the freedom of choice, or the authority to make the decision. So with that, then I'm thinking about soft paternalism sort of as a framework of the decision-making process that these managers go through. And if we think about their long-term goal, or the vision, like I said, is the residents' well-being, which is achieved through supporting their autonomy, then they are, in these discussions, they are educating or informing about the disease process, what they can expect, but also the potential consequences of their decisions. And then they are persuasive in the way that these discussions take place towards quality of life and autonomy. But in the end, the resident, or the family member in some cases, but the resident makes the decision about their care. So with this framework, it's a little bit I don't know, kind of the opposite. It's really hard to get my thinking around it sometimes, but they're acting paternalistically in order to support resident autonomy, which is what you would think, you think that they would be in contrast to each other if you're acting paternalistically. Sometimes that would be using restraints or limiting a person's freedom, but they're saying in these discussions they are persuading, but it's in order to support a person's autonomy. So I would be happy to have your feedback on that as well at the end. So now I want to move on then to the third theme, which is about the factors that interfere with the vision. And so these are things that would stop autonomy from being totally preeminent. And one of them is they are still responsible to deliver care. And sometimes this is very medical care. This is not just about a person living their life, but sometimes there is medical care that has to be delivered. And they have to protect a person. And so there's a lot of variation in the administrator's views, or the manager's views on how they approach locked doors and security of the environment. So some of them say, we tell the family members that our doors are not locked. And so the person they're taking the risk by moving in here, if the person has dementia. But we say that the doors are not locked, but then there is a receptionist at the door. So technically they have the freedom to leave, but there is a receptionist who is intercepting and maybe redirecting a person from exiting the facility. Some of them wear bracelets where they have only access to certain parts of the facility, and some of them can exit the home freely, some of them cannot. And then some of them just have a totally locked, secure environment at all times. And this is something that a lot of them are grappling with, and I think is also not just in the Netherlands, but long-term care in many, many places. So this person said, which first she expressed her personal opinion is that people should be able to exit freely, even if they have dementia. But she said, in the dementia world, everything has to be locked. If that electrical system malfunctions, and we have not noticed it in advance, and people can get out without us noticing, then it is a risk, and then we have a big problem. But that is my responsibility because they live in my house because I have a lock on the door. So you can see, although this is not how she personally feels, she knows that she's still responsible to provide a secure environment. And then this person said as well, when it comes to rules and regulations, yeah, we focus more on quality of life, but we still have these rules and regulations. So you can see there's a tension where they feel that they're still responsible for certain care regulations, but they are still trying to focus on quality of life. Something else that they talked about is that when these interviews took place, the care inspector was still in transition from the old way of performing an inspection to the new reformed way. So the managers expressed that they were not able to predict necessarily like what a person might be focused on when they come into the home to inspect. This person said, in the past, when they, meaning the care inspectorate, came here, they said, well, we have brought a form, and they had lots of questions. Check, 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 check. Here's your problem. Now they ask, what do you want to achieve? How do you involve clients in it? So it's more an advisory, more than a checklist. But do not mistake, they also have the checklist. So although they want to focus on quality of life or well-being, there's still some things that have to be regulated. And that's, you can see the tension there. So those, yeah, again, just the three themes. And a couple of limitations were that the interviews were done in English, which is not the native language of the managers, but they were told from the beginning that it would be in English and only interviewed if they were comfortable enough. And also, this is just the manager's perspective, which could be seen as a limitation because it's not including like a resident's perspective. But I think, like I said, it's very important to understand their opinions and their perceptions of autonomy in order to understand how it is displayed within the nursing home. So that's it. Thank you all very much.